when I'm graduating next to 10th of August, then I will apply for that.
Yeah, absolutely. The idea of being online, my days starts usually 5 o'clock in the morning and it doesn't finish until 11 at night. But it's like I'm taking the time to work out no matter what, taking the time to do what I need to do no matter what. So we just gotta push it. Gotta push it through it. Hopefully, my idea is that in 8 weeks, I know some of you guys will test before that. But if you're starting today, in 8 weeks from now, giving that one module per week, and then we got the crash course, which is module 6, and 2 weeks to adopt your strategy should you be missing something. I think 8 weeks is the sweet spot, right? Okay. If you hit it really, really hard for 8 weeks, that's a sweet spot. Now, that doesn't work for everyone. Some people is able to do in 3 weeks. Some people wants to take 6 months, so it doesn't matter. But for those that want to follow along with the live lectures, you should put in your calendar 8 weeks from now. Everyone, I hope everyone is board certified, right?
Thank you.
Yeah. So this is super exciting. So let me see who else passed today. Mary passed. There was 2 other students that passed.
She never attended the classes. She was working full time, but she did everything else, like read the material and she did the question and answer.
Yeah. I mean, it is the power of doing it. The classes is great just because it kind of get to allow you face-to-face time, and that's kind of difficult questions. Every once in a while something new comes up, we all can learn from each other, so it is great. But you don't need to, because everything is recorded and everything is in a PDF.
Yeah, that's what she said, that she read the PDF and she passed, and I'm hoping I'm gonna be too now. Because
no, I mean, it's a good motivation to to see your friend passing, and kind of also serves to solidify what we are doing. For you guys might be a new experience, but I've been doing this for 4 years now. Over 2,000 students have passed with us. Last year was the largest amount. And then there's just every single day, 2, 3, every single day. Sometimes those during the previous crash course review, after that was like 20 at one day. So just keep pushing, guys, keep pushing. I mean, this is to me is the biggest dream ever. When you kind of like become your PMHNP board certified and you start your own practice, or dictate your own hours, or you work from home while you're traveling or whatever. It's a very different gig than it is being a bedside nurse, and I love it. To me, it was one of the best life experience changes ever. So, so it is indeed, I hope it will make it as good of a life experience for you guys. So,
thank you, Dr. Lopes.
Yeah. So doesn't matter like how much you study if you don't revise the material. You can go through everything and never go back to module 1. You're going to forget, right? So keeping that in mind, what are we going to do now is quickly, very, very quick, in 10 minutes. Let's see if I can do this in 10 minutes. So we're going to go over everything we went over in 3 hours. So just if you were not here yesterday, obviously this is not going to be very beneficial to you, but just kind of like very quickly, right? We talked about the cerebrum.
Yes.
We talked about the 4 lobes, right? More specifically, we talked about the Broca's area, which is in the frontal lobe, responsible for expressive speech. When we say frontal lobe, we always got to think of executive function and personalities, right? Specifically personalities, high yield, expressive speech, not to confuse with receptive speech. And this is just flexibility, language, insight, planning, all the complex tasks that we have in the frontal lobe, the most developed lobe, right? And then we talked about the temporal lobe, and we said hearing, keeping what we hear, memories, right? So if one has auditory hallucination, it may be due to the temporal lobe. Receptive aphasia is being able to understand what is being said, and that is due to the temporal lobe. Amnesia, which is the memory, right? Hearing, keeping it. Amnesia, it is part of, or memory, in this case, temporal lobe. Okay. Again, receptive aphasia is also called the Wernicke's area in the temporal lobe. So hearing, understanding, keeping the memories, and amnesia, right? And the behaviors. So here we go. All right, when we say occipital lobe, we are going to think about vision. And one of the great examples of that in psychiatry is visual hallucination. It's all about the occipital lobe, right? Now, a very important lobe, just as any one of the other ones we mentioned to you, is the parietal lobe. First thing, parietal is all about taste, reading, and writing, right? It's all about the sensory, feeling the warmth of the air or the cold wind or a cup of coffee, right? It's all about the sensories, reading, tasting, and writing. When we say parietal lobe, you got to think of the clock drawing test and constructural apraxia, which is building blocks, right? Which also we got to think about asterognosis, right? Which is the inability to identify an object with the closed eye, just by feeling, right? So we talked about that. So this is the parietal lobe, smell, hearing, taste, all the sensories, the touch, reading and writing. And don't forget the clock drawing test. Why we do a clock drawing test? Because it's easy, 2 minutes. What is the population? Alzheimer's population. And what it indicates if the patient cannot do the clock drawing test, right parietal or right hemisphere. Okay. All right. So this is an example of the clock drawing test, what the good looks like, the perfect one, and everything else from minors to imperfect, completely unreasonable, right? We talked about the limbic system, the thalamus. Under the thalamus is the hypothalamus, amygdala, and the hippocampus. So when we talked about the hypothalamus, we say what the heck, which is for water, hunger, appetite, T is for temperature, H is for hormone, E is the sex, libido, which is not really a E, and the C is for circadian rhythm. So that is the hypothalamus. Under the thalamus, the thalamus controls the sensory so that our brain is not overloaded, right? It lets one sensory at a time, almost simultaneously, so we are able to capture those senses and still be able to feel them. Hippocampus. If the question says is stress, think of the hippocampus. Hippocampus is what converts short-term memory to long-term memory, right? When we sleep. That's why sleep is important. If you want to pass your test, you got to be able to sleep. You know, take few naps and then go right back again. Do not confuse the stress with the medulla because it does not belong to the medulla. A medulla is smells. So the thalamus is all the sensory but smell. A medulla is smell, anger, and fear, aggression. Amygdala. If the question says the stress, think of a hippopotamus that's stress in jail or cage. What else did we cover yesterday? So this is again, the frontal lobe. We talked the basal ganglia, which is all about the movement, the temporal lobe, memory, hearing, auditory hallucination, hypothalamus, what the heck, brainstem, where all our must have in order to live, breathing, swallowing, heart rate, blood pressure is monitored from. The cerebellum, it is about balance, right? About balance. The thalamus is a sensory, and the occipital's also about the vision, as we mentioned. Now, parietal also is about spatial reasoning, where you are in space, right? Right. We talked about the cranial nerves, and just gonna go very fast over this. We talked about the dopamine pathway. The reason atypical is because of the 5-HT2A. Atypical comes with more metabolic syndrome and less EPS. Typical, or the first generation, does not have 5-HTA. This is very important, okay? This will very likely be in your test. Typical does not have 5-HT2As, so therefore, patients are more likely to get EPS symptoms, but less likely to get metabolic syndrome. The mesolimbic pathway is postulated that the increase in dopamine produce or modulates the positive symptoms of psychosis. Mesocortical pathway is postulated that decrease in dopamine is responsible for the negative signs of schizophrenia. Nigrostriatal, we have two dopamines that are kind of fighting against each other, is the acetylcholine and dopamine. When the dopamine is blockaded, there is very little of dopamine available. Acetylcholine increase, therefore you have your EPS symptoms. For the test, you are going to answer as in EPS is due to the low dopamine availability blockading this pathway, and therefore acetylcholine is increased, causing EPS symptoms. The tubulofundibular pathway, the problem here is prolactin, and again, dopamine. Inverse relationship between acetylcholine, dopamine, in the nigrostriatal pathway. Tubulofundibular, the same thing with prolactin and dopamine. When dopamine is low, prolactin is high, causing amenorrhea, galactorrhea, sexual dysfunctions, gynecomastia, and osteoporosis. Osteoporosis, you will very, very likely see two questions on this. One is, which pathway is related to osteoporosis? Then you got to remember tubulofundibular. And the second question that often comes up is, who are the folks that are at risk for osteoporosis, which we covered in the crash course review, okay? All right, so when we arrive to the EPS symptoms, we have Parkinsonia, acute dystonia, akathisia, and Parkinson disease. Acute dystonia, right? It happens because of the dopamine blockade. So therefore you have more acetylcholine. Acute dystonia, within acute dystonia, you have a subdivision that's called oliguric crisis. This is high yield because it's an emergency. And what do you have to do for acute dystonia? Cogentin or Benadryl, which is a antihistamine. Remember, the reason that's high is because the histamine is high. So you want to give it a antihistamine. Okay. Now, akathisia, right, is restless, I'm moving back and forth. For akathisia, you are to remember two things. One is to give beta blocker or cogentin. If the question has both of them, pick beta blocker. Now, what scales do you use for akathisia? The Barnes scales. Barnes akathisia rating scales. Okay? Akathisia, beta blockers. Look at that. She's restless, right? Akinesia is the lack of movement. And for that, you give cogentin. Do not confuse akinesia with akathisia. Okay, Parkinson-like symptoms due to the D2 blockade. And we talked about TD. We said that there are two medications. They are FDA approved, which is called Austedo and Ingresses. However, for the test, you really want to decrease the dose first, and then you can try something else later, such as Austedo and Ingrezza. What you are not going to do is give cogentin. Cogentin is contraindicated. Very high yield, Reglan, also can cause TD or EPS symptoms. So if your patient is on an antipsychotic plus Reglan, is a problem, right? We said do not confuse pharmacokinetics, is what the body does to the drug. And we talked about ADAM, absorptions, distribution, metabolism, and excretion, right? We talked about also this has to do with inducers and inhibitors, right? This is what the body does to the drug. We talked about inducers, the acronym, drop, act, scam, GBS. And when we say this is for inducers, right? So less of the medications available. And here's an example of inhibitor. When you start with 3 substrate of risperidone, you add an inhibitor, more risperidone is available at the end of the day, because the inhibitor here is a 2D6. Okay. Now here is where I kind of want to stop a little bit. So see this one. This one is an inhibitor, right? Valproic acid. You can memorize sickface.com, but just remember valproic acid for now as an inhibitor. We talked about the combinations of olanzapine and clozaril and the smoking. We talked about the elderly. How do they metabolize drugs? We said that you have to memorize decreased intracellular water, low protein binding, low body mass or muscle mass, and reduce metabolism. The only thing that they have increased is increased body fat. That is for the elderly. The young folks, children, they have a faster metabolism. And we talked about renal insufficiency and acute injuries, renal injuries in relationship to lithium. We talked about agonistics, antagonistics, partial agonistic, and what else? And antagonistic, right? So very important that you know this definition as it states. Agonistic activate a receptor biochemical to produce a biological response. So agonistics produce a biological response. Partial and agonistic, it produces half of that. It binds to the receptor, but does not fully activate. Inverse agonistic, it binds to the receptor and does the opposite of the biological response agonistic would do. Antagonistics, it sits there in the receptors and does nothing, not allowing a chemical to attach to the receptor. Very important, you will get a question or either on agonistic over reverse agonistic or antagonistic. And if you don't know exactly as it states here, you might miss a few questions here and there. Okay. All right, we talked about neurotransmitters. Serotonin is made in the Raphael nuclei. Talked about the dopamine, nucleus accumbens, ventral tegmental area, and substantia nigra, norepinephrine, lucus coeruleus. I have no doubt that you will get a question, a minimum 2 questions from either serotonin, norepinephrine, or dopamine, what is made. Okay? So norepinephrine, locus coeruleus, and or acetylcholine, which is synthesized by the basalis nucleus of nerve. Okay. GABA, the most inhibitory neurotransmitter. Glutamate, the most excitatory neurotransmitter. Right? We talked about lithium, neuroprotective treatment for bipolar, has been shown to reduce suicidal behavior in bipolar population. If the question asks which drug has been shown to reduce suicidality in schizophrenia population, then it is clozaril. We talked about the low therapeutic index, 0.6 to 1.2, and we talked about stopping the medication at 1.5. At 1.3, assess. If there is symptoms, stop. No symptoms, continue. 1.4, assess. If there is symptoms, stop. If there is no symptoms, continue the medication. Talked about you need to get to your TSH level because it causes hypothyroidism. So here is what I think Mavis was asking yesterday, right, Mavis? If you are here today.
Yes, I'm here.
Okay, so this is what you asked, right, last night?
Yes.
So here, what I'm saying is when there's hyperthyroidism, it can mimic mania-like. When there's hypothyroidism, it can mimic depression. But I can see why you asked this. It's kind of a little bit, I should have put it here. If it's hyper, it mimics hyperthyroidism. If it's low, right?
Mm-hmm.
I mean, it mimics depression, but I see what you're saying. For sure, I'll make this a little bit more clear next time. But you understand, right?
I do.
Okay. So you got to get BUN and creatinine to assess your kidneys, the patient's kidneys. Always get a pregnancy test. Anytime you see a pregnancy test on the test, most likely that may be the answer. And get an EKG because it's caused the T inversion in older adults. Again, hypothyroidism, fine hand tremors, side effects, maculopapular rash, cardiac T inversion, and leukocytosis. These highlighted here are very likely to be asked. If you see curse, hand tremors, is a sign of toxicity and not necessarily side effect. If you do have a question, please go ahead and ask.
Yes, I was wondering if for a patient, if they have a question and it says the patient is in the emergency department and presents with those symptoms, and it has there the selection is EKG and then vital signs, and then it says stop the lithium. Would we address the issue EKG first? Okay, and in that setting, and then if you're in the clinic setting, you would do the other, correct?
Yeah, so like if you get a phone call, or clinic, yes, in your office, things like that, you really want to discontinue the medication. However, in this specific question, is referring the patient is already in AD. At that point, the patient is not taking their medication. what would be the most valuable thing for you to do, right? In this case, it's because of T inversion and dysrhythmias. So in this case, getting an EKG would be the most valuable, but it is a tricky question, okay?
Okay, thank you.
When we see lithium toxicity, or we think there is lithium toxicity, the first action is to stop lithium, right? We said never really mix lithium with the ARBs, ACE inhibitors, thiazide, and NSAIDs, for example. And all right, and I think this is where we stopped. So this was a little bit more than 10 minutes, as I trying to finish in 10 minutes, where we covered in 3 hours, difficult task, right? So this is what we covered yesterday, and we are going to start right at valproic acid. So remember, one of the reasons I did this quick review is so that you can see